Assalamualaikum, you all boleh dengar?
Dengar ada.
Boleh dengar sekejap Do you get my slideshow? Ataupun dia dalam bentuk ni lagi? Sekejap.
Dia belum presentation mode lah. Dia still dalam PowerPoint. Yang ni slide.
Slide dah Sekejap. Give me some time a bit. Oh, sorry. Everybody is here or still perlu menunggu sesiapa? Masih perlu menunggu sesiapa ke? Atau I can start saja?
Boleh.
Okay, I start je. Alright. Okay. Assalamualaikum warahmatullahi wabarakatuh. And good afternoon. I'm so sorry that we cannot proceed with face-to-face punya class since cases is rising everything lah. So agak susah sikit lah, but tak apa, kita boleh cuba secara virtually. And thank you to the pediatric department lah to invite me to become one of the speaker lah untuk topik cerebral palsy. Okay, I am Dr. Shahizan. Previously I was graduated daripada AUM jugalah. Okay, pada tahun 2004. Okay, I was the third batch from UIA. And after that I proceed with my master in rehab medicine at UM. And it's already about 9 years lah. Okay, I've become a rehab physician and I've been transferred here since 2013. Okay, alright, that's enough for my pengenalan lah. Today I'm going to talk about cerebral palsy, and I do hope that some of you ataupun all of you should already read something about cerebral palsy lah. Okay. So my content will be the historical background on CP, the epidemiology, risk factor and etiology, classification of CP, how to diagnose, and what is the associated deficit with cerebral palsy, and the management on CP, as well as what is the functional prognosis and aging with CP. So for the background, previously CP described as cerebral paresis, okay, was first used in 1843 by Dr. William Little. Okay, so last time it was known as Little disease. Okay, but however, in 2004, an international multidisciplinary group revised the definition of CP as a group of permanent disorders of the development of movement and posture causing activity limitation that are attributed to non-progressive disturbances that occurred in the developing fetal or infant brain. The motor disorders of CP are often accompanied by disturbances of sensation, perception, cognition, communication, and behavior. Okay, the definition and classification of CP in April 2006 by Peter Rosenbaum described CP as a group of permanent disorder of development of movement and posture, which will cause limitation, activity limitation that are attributed to non-progressive disturbances that occur in the developing brain. Okay, and sama jugalah the motor disorder of CP are often accompanied by disturbances of sensation, perception, cognition, communication, and behavior. Alright, so what since the definition is too long, okay, kita kata banyak, okay, so kita kena equate kan apa maksud permanent tu. Okay, permanent does not equate to static, okay, because children and CP and adult with CP can have a changing pattern of clinical manifestation as they grow up. Semakin besar, okay, semakin besar murid, kanak-kanak, so semakin besar dia akan ada change in the pattern of the clinical manifestation itself. And disorder of development distinguish CP from acquired brain injury, okay, that occurs after basic motor development has occurred, okay, which it means that kalau dalam acquired brain injury which happen after the basic motor development, kita akan panggil tu acquired brain injury. Kalau macam CP is a disorder of development because motor development masih lagi belum fulfill, belum full, okay, does not really maksudnya tak ada lagi, belum achieve, and then there is maksudnya ada masalah semasa brain tu masih developing. Okay, sebab tu kita panggil CP as disorder of development. Okay, there was no upper age limit specified the onset of the disturbance of developing fetal or infant brain because sebenarnya within the first 2 to 3 years of life, okay, is identified as a crucial period for insult, okay, in brain of a child because budak punya brain masih lagi developing towards sampai umur 5 tahun. Okay. Okay. Boleh I tanya tak sini sebab I lupa. Is there any international student here?
Ada seorang.
Ada seorang. Oh, because I mix kan bahasa Melayu dengan English, so I takut tidak faham. So sorry. So if there is international student, then I should use English as the medium lah. Okay. So sorry lah, lupa tadi nak tanya. Alright. Insult to the brain is non-progressive, which means the pathophysiologic mechanism are presumed to arise from a single inciting event, which are no longer active at the time of diagnosis. It means that in CP, kata insult, we say that insult to the brain is non-progressive because it happened only once. Okay, happened only once during in specific time only, not longer activity atau longer active time. So hopefully you understand because the definition is too long. Okay, so what is the epidemiology, okay, for CP? Okay, it's been said that about 1 to 2.3 per 1,000 live births happen. Okay, and early diagnosis is helpful to initiate services, but of course it can falsely elevate the incidence of CP. Okay, when you diagnose early, so the incidence will increase, but maybe you have falsely diagnosed CP. Okay, 50% of children with CP who diagnosed before 2 years of age can have spontaneous resolution of the symptoms. Okay, that's why kita kata kalau that's why I say that if you diagnose too early, you will see that 50% of children would have spontaneous resolution of the symptoms because depending on the brain development of the child. Okay, in developed countries where sufficient data available, the general trend has indicated relatively stable incidence over 30-year period, which it shows decline trend in view of widespread usage of assisted ventilation. Yeah? and also the ability to keep the premature low birth weight less than 2.5 kilo to extremely low birth weight less than 1 kilo infant survive because of the, we said that the modernize of the treatment for premature babies. Okay, what is the risk factor for developing, for CP? Okay, that is that it can be divided into few factors. Okay, you can divide into general, maternal, and then risk during gestation itself, as well as the fetal factors. Okay, if general, okay, usually if the gestational age is less than 32 weeks or birth weight less than 2.5 kilo, is the risk, okay, risk in CP. Okay, maternal history, okay, if the mother has mental retardation, seizure disorder, hyperthyroidism, okay, and as well as history of 2 or more prior fetal death, okay, and siblings with motor deficits, okay. And then if during gestation, if the patient presented with twin gestation, fetal growth retardation, third trimester bleeding, okay, you know that this is the risk of the baby that inside the womb of the mother would have a risk to get cerebral palsy. If the mother has increased urine protein excretion, which shows pregnancy-induced hypertension, okay, chorionitis, premature placental separation, as well as low placental weight. Whereby fetal factors are abnormal fetal presentation, fetal malformation, bradycardia, and neonatal seizures are the factors that leads to high risk of to get cerebral palsy. So what is the etiology, the causes? Okay? You can divide into prenatal, perinatal, and postnatal. Okay, for prenatal, torch infection, okay, intrauterine stroke, toxemia, genetic malformation. Where perinatal is whatever yang happen during pregnancy itself, during delivery, okay, placenta abruption, cord prolapse, uterine rupture, any injuries leading to birth asphyxia. And postnatally, all CNS infection, cerebrovascular insult, acquired brain injury, anoxia, chronic trust, and progressive hydrocephalus. So how to classify cerebral palsy? Okay, you can divide into either tone pattern or the distribution of the limb involvement. Okay, both can be used simultaneously, but it all depends on how you describe the patient. Okay. Okay, the frequency, most of the CP patients, 75% of cases are spastic, okay, if according to the tone pattern, and the distribution of limb involvement are diplegic usually, okay, and 25% of cases are dyskinetic. Dyskinetic ni is kita kata attitoid, coriform, ballistic, ataxic, hypotonic or mixed, okay, and usually is the less common one, and it can involve either quadriplegia, involvement of the all 4 limbs, hemiplegia or triplegia. Okay. Okay, this is from Natus Anatomy. Okay, I like Natus, so it's easy to describe things when you look at the presentation of the patient itself. Okay. You all can you all see my cursor moving?
Yes.
Yes, okay, so all right, because when we do class as virtually, so I cannot see you, in front of me, so usually I will ask the student to answer directly to whatever I ask lah. So I do hope you can understand well during my presentation this time. Okay, if you can see the cursor is good. Okay, this is what we call hemiplegic CP. Okay, when the involvement is only one side of the body. So you can see at the brain. Okay, for at the brain kita kata lesion is only part of the one part of the brain, okay, one part of one side, okay, and usually is a regional, kita panggil is a regional involvement, and this shows is a most commonly is a spastic, okay. Diplegia means the involvement of all limbs, but however, the presentation is more on the lower limb compared to the upper limb, okay, and the presentation is more on the distal part, okay, diplegia, and from the brain overview, you can see the involvement is over here, both of the central part of the brain, which if you relate to the homunculus presentation, the central part need control the movement of the lower limbs, and the outer part control the upper limb. Okay, you need to relate back to your anatomy. If in the homunculus presentation, upper limb is at the outer part of the brain, and the inner part is lower limb. Okay. Therefore, the lesion at the brain is more on the middle and the middle part lah, okay, the inferior, the dekat dalam, okay, compared to the outer. And the quadriplegia means all four limbs affected, including the body, and the lesion is from the inner, okay, until the outer part. Okay, kalau kita relate, and it's two sides, okay, right and left, okay, and all these three are from lesion in the pyramidal tract, ataupun kalau macam I, like me, I will use this, kita kata ada lesion in the cortical part, okay. When there is movement ataupun kita kata additional movement of the dyskinetic or ataxia, the lesion is all below the cortex atau cortical, subcortical region lah kita panggil, and all this will lead, all this will call extrapyramidal signs. You all belajar, you all also learn what is the extrapyramidal signs, like patient who have apa contoh yang ada extrapyramidal, what is the example of disease with extrapyramidal lesion? Parkinson, yes, good. So Parkinson is one of extrapyramidal lesion. So the lesion is at the below the cortex. Yeah, above, okay, kita kata dekat all the outer part of the brain is cortex. The inner part of the brain is below subcortical. Okay, so when there is lesion in subcortical region, it will lead to attitoid movement, dystonic or ataxic, and it all presented with different kinds of movement. Okay, so hopefully you can understand. If not, then you can ask your leader to take my slide lah later. Okay. Okay, however, this classification system does not provide an adequate picture of the child's functional or cognitive status. Of course, it just describes the presentation or the features of the child itself, but it does not relate to the functional or cognitive function of the patient. So what do we use in classify the CP patient? We use gross motor function classification system, or GMFCS. It is most widely used. It has 5-level scale with age bands with less than 2 years, 2 to 4 years, 4 to 6, 6 to 12, and 12 to 18 years. And this GMFCS stratifies children based on their gross motor ability, self-initiated movement, in particular emphasis more on sitting, walking, and wheel mobility. Okay, the distinction between level based on the functional ability of the child, the need for assistive device, including handheld mobility devices or wheel mobility, as well as the quality of movement. And this classification has excellent inter-rater reliability for both children younger than 2 years old and also children more than 2 years old. Okay, this is what we use in our clinic. Okay, when we see patient with CP, we will classify or stratify them into which level according to their age group. Okay, this is a general GMFCS classification. Okay, for level 1 mean the child walk indoors and outdoor and able to climb stairs without limitation, and the child can perform gross motor skill like running, jumping. Okay, but the speed, balance, and coordination are impaired. Okay, if it's normal, then bukan CP lah, it's not CP lah. Okay, so they must have some speed ataupun issues with balance, coordination. Okay, level 2 means the child walk indoors and outdoors but climb stairs holding onto the rail. Okay, and also experience limitation walking on uneven surface and incline, as well as walking in crowds or confined space. Okay, whereby in level 3 means the children can walk indoors and outdoors on level surface with assistive mobility devices. Okay, they may able to climb stairs holding on railing, but they also use wheelchair manually or transported when traveling or for long distance outdoor uneven terrain. Maksudnya they use walking aids for short distance, long distance they need to use wheelchair. This is level 3. For level 4, children may continue to walk for short distance on walker, but rely more on wheelchair lah, okay, at home or school. In level 5 means physical impaired. Okay, there is restriction in voluntary control of movement. There is also problems with ability to maintain anti-gravity head and trunk posture. Okay, you see the most of the child with CP in level 5 means they unable to lift up their head. Okay, and all areas of motor function are limited. Then they have no independent mobility. They need to be put on a wheelchair to be moved around. Okay, so this is the summary. Okay, level 1 means walk without restriction, limitation in high level skills. Okay, level 2 means walk without device, but limitation walking outdoors. Okay, they still have limitation on uneven surfaces. Okay, level 3, walk with devices, but they have limitation walking outdoors and using wheelchair for long distance. Level 4 means limited mobility and power mobility outdoors, where in level 5, very limited self-mobility and even with assistive technology. This is summary lah from the GMFCS. Okay, how to diagnose child with CP? You have to start from taking history. A proper history taking will help you to make a better diagnosis. Okay, you need to look for significant history in birth history, history of delayed developmental milestone, history of asymmetry movement from the mother. And after you take history, you need to do a thorough physical examination. Okay, you need to look in the abnormalities in tone, reflexes, posture. Okay, is there any persistence of primitive reflexes? Okay, is there any delay or abnormal gait pattern or any abnormal pattern of movement if it's involved subcortical cerebral palsy, like such as ectotoid, ataxic. Okay, you need to see. So what are the early signs? Okay, when you examine a child. Okay, in infancy. Okay, if you see that the child is stiff or floppy, then you know this is signs of neurological problem. Okay, if the child, when you lift up, then they can maintain this posture. Okay, they can straighten the head together with the trunk, then this is normal. Okay, and then if there is any history of excessive lethargy or irritability, high pitched cry, okay, poor head control, weak sucking, tongue thrust or tonic bite, and any history of feeding difficulties. This is all the early signs during the infancy, 0 to 3 months. You have to ask the mother, ada tak anak macam ni? Ada tak anak ni macam ni, macam ni? So you have to know what to ask, you have to know what to see. Alright, this diagram shows the difference between the normal development and the CP1. Okay, over here is the normal development. Okay, by 3 months, what they can do, by 6 months, okay, 9 months, all these are on the development chart, milestone. What chart do you use? Hello? Anybody can answer my question? What developmental milestone chart that you use usually when you see patient?
In the PITS protocol.
Yes. In whatever you know that you learn from your pediatrician. You ada kan PITS protocol? Okay, so what is the name for the developmental milestone chart? And you all final year ni, you'll be asked that during your long case or short case. Who wants to answer?
Is it called the Denver Development Screening Tool?
Of course, Denver lah, kan? You all use Denver, right? You need to know by now, by 3 months, by 6 months, 9 months, 12 months, 18 months, what the normal child can do. If let's say you have a case or long case, and definitely you will have CP case for your long case, as well as your short case, you need to know what developmental milestone you use, the chart that you use. Definitely you will be asked. So please don't forget about it, okay? So I'm not going to elaborate more because I know that all of you had by now know Denver by just macam ni kita kata kan, petik jari, okay? Just petik jari tahu dah bulan berapa. So, kalau nasib baik bukan face to face class, kalau tak I datang ni dah siap-siap, okay? Nasib baik kita buat just virtually kelas ni. Alright, so you have to know, and when you see there is abnormalities or difference from the normal Denver chart, then you need to, there is a strike in your mind that the child has a problem, okay? How to diagnose CP? Okay, you have to do neuroimaging, okay? You can use cranial ultrasound in premature baby for evaluation of the periventricular leukomalacia. You can also do MRI or CT scan, but MRI has high yield of greater 80% in identifying abnormalities, okay? But not all hospital has MRI. You need to remember that. So you can also use CT scan to see any abnormalities. It's just that there is differences between MRI and CT scan lah. Okay, MRI has 80% in ability to identify abnormalities. Okay, and this neuroimaging can aid in determining whether the injury was prenatal, perinatal, or postnatal. You might also can do blood investigation. Okay, children with hemiplegic CP have high incidence of prenatal or perinatal cerebral infarction. So you need to look for any coagulation abnormalities. Again, Is there any deficiency of protein C or S or elevated lipoprotein A level, which leads to coagulation problem, and as well as presence of anti-cardiolipin and anti-phospholipid antibodies in autoimmune disorder. Okay, what are the associated deficits in CP? Okay, I divided into system. I divided into system that involve in system that are in our body. Okay, we start with central nervous system, the upper part. Okay, the higher part. Okay, most of the children with CP will have mental retardation, and most common in rigid, atonic, and severely spastic quadriplegia. 50% of them have seizures, okay, and which frequently in hemiplegic and spastic quadriplegia also, okay. They might have cortical sensory deficit in hemiplegic CP. Okay. They will have a hemisensory loss if they are hemiplegia. It's just like presentation of stroke, okay. Most of the CP child will have behavior issue. They have attention deficit disorder, easily distractible, okay, impulse control, overt hyperkinesis, as well as organic pseudobulbar palsy, which they unable to swallow very well. Okay, also will have some issue with kita kata emotion. Okay, and most of them also will have language disorder, which have a delay in speech, as well as in coordination of muscle innervated by lower cranial nerve, especially to the tongue. Okay. And then secondly, visual system. Okay, they will have strabismus, hemianoxia, okay, in hemiplegic CP. Hearing impairment, if the CP caused by torch infection, then you need to rule out any hearing impairment, any kernicterus issue, which can lead to bilirubin encephalopathy. Okay, dental and oromotor system, which the CP will have animal dysgenesis, malocclusion, okay, caries, very bad caries, and gingival hyperplasia. They also will have difficulty in sucking, swallowing, chewing, okay, drooling of saliva. Then we go down to pulmonary system, which they will have deficient ventilation, bronchopulmonary dysplasia especially in premature infant, micro aspiration with oromotor dysfunction. For the GIT system, they will have reflux, constipation, dysphagia, malnutrition. In orthopedic, of course, when we mention orthopedic, it involved with the bones and soft tissue. They will have scoliosis, multiple joint contracture, either hip or shoulder subluxation, dislocation, and bowel bladder system will have this function of central neuromotor control and cognitive developmental. Therefore, they will have usually a neurogenic bowel and bladder. For feeding, growth, and nutrition, most of the CP will have malnutrition due to ineffective swallowing, and usually we suggest mother for enteral feeding, either through nasogastric tube or gastrotomy tube. And poor growth are related not only due to the malnutrition, but also due to hormonal imbalance. The common hormone deficient in CP child is growth hormone. Okay? And other neurologic issue that we have is neurologic issue lah, epilepsy. Okay. Okay. Oh, so this is this is including the management for the patient of CP. Okay. For medical management, this is what we do. Okay. You need to look at the growth as well as the nutrition. Also, you need to look on the neurologic issue, which if the patient has epilepsy, you need to treat with anti-seizure meds. I'm so sorry, just for a while, I need to answer a message. Okay. Other medical management that can be given to the patient according to the system also. Okay, I put into the system so that you can understand well, and if it's good if you can answer like this during your exam. You put it in according to the system, so you will not miss anything. Okay. Pulmonary system you can give if there is infection, you can give antibiotic, and if there is issue with secretion clearance, or you can give bronchodilators. Okay. For genitourinary, you can do early assessment on voiding dysfunction, and it is important you refer to the PITS urology for urodynamic evaluation. Okay, for earlier assessment. Okay, for gastrointestinal, okay, of course they will have constipation, so you can give high fiber diet. And if there is issue with any reflux, you can refer to the surgical team. Okay. For osteoporosis, you can give vitamin D and calcium supplementation, and diet consists of high protein and calcium. For rehab, okay, therapeutic rehab, you can start early intervention program. Okay, by training the family. Okay, you can look into the psychology issue, what assistive device that you can give to the patient. Make sure that the parents have any social atau work support. Okay, group therapy. Okay, for them to know how to manage the child. It is started as soon as possible once noted there is delay in developmental milestone. Okay, and usually kita nak aim to maximize the function as much as possible in the safety, as well as need them to be independent. So this is part of early intervention program that you can give. Okay, you can start to roll them on a ball. Okay, some passive movement, lying down on floor. Okay, as well as put them on standing frame. Okay, this is standing frame lah, and let them read while standing. For other parts, okay, you can start them on partial weight bearing treadmill. Okay, this is available in Hospital Rehabilitasi Ceras. If you have a chance to go there, then you can see. Okay, in Hospital Rehab Ceras, there are a lot of new equipment and modern equipment for rehabilitation. We can also put patient on pool therapy. Okay, let them swim together with the therapist. Okay, also available in HRC. Over here, we don't have a larger pool. We have smaller pool, but however, due to some problem with the motor pump of the water, we cannot use our pool at the moment. Okay, you can also put patient therapy while riding a horse. Okay, and put and give and let them have outdoor activity lah. Okay. Okay, this is the equipment prescription that can be given to them depending on their level of function. Okay, if the child able to walk, can try to stand up. Okay, it's good if we can prescribe a walker. Okay, as well as let them involve in any sport activity. Okay, if they have improved in terms of motor control and as well as power. Okay, if let's say the child might not able to have a good outcome with standing or playing games, they can also be put on a wheelchair. Okay, this is a self-propelling wheelchair. This is a motorized wheelchair. This girl is on motorized wheelchair. But however, you need to look at the cognitive function of the child, whether they able to understand how to use the motorized wheelchair. Okay, so itu antara komponen, that is one of the component that we need to evaluate before we prescribing any mobility devices. Okay. So what are other rehab management that we can give? Okay, if there is hypotonia, okay, there's no standard approach, but you can start with passive range of motion exercise. Okay, stretching of the muscles involved, let them to be in a full hydrotherapy, and start them on oral medication if the spasticity is worsening. Okay, you can either give them baclofen, diazepam, okay, or we can give them chemical denervation such as selective neuromuscular botox injection or phenol injection to the muscle that is spastic. There are also role of intrathecal baclofen, which the medication delivered to intrathecal space via a catheter connected to an implanted pump in abdomen, and usually to treat children with generalized spasticity or dystonia, which cannot be treated with not enough be treated with oral medication. Okay. Selective dorsal rhizotomy also can be done to treat spasticity, which usually they do a single or multi-level osteoplastic laminectomy, exposing the L2 to S2 nerve roots, okay, which lead to reduce in the spasticity severity. Okay, this is what I mean on intrathecal baclofen, where you put the pump at the abdomen and there is a wire inserted at the level, usually level 2 lah, okay, and this baclofen will help to reduce the spasticity of the muscle generalized. Okay, we don't have this service, but we do have these services in HKL as well as in Hospital Raja Permaisuri Bainon, Perak. Okay, where selective dorsal rhizotomy, this is how they do it lah. Usually they open up, okay, they do at L2 to L2 level, and selective dorsal rhizotomy is being given at about 25% of the nerve roots. Okay, so therefore it will reduce the spasticity. Okay, it will not eliminate 100%, but it only reduce the spasticity to a minimal level, because we cannot just do 100% dorsal rhizotomy. They will have loss of sensation, and it will worsen the neurogenic bowel and bladder complication. In orthopedic, in orthopedic management, children with CP will have abnormalities in muscle tone. So therefore, they will have joint contracture, okay, or bony deformities. Okay, example of management by orthopedic. This is summary lah. Okay, the orthopedic team can do muscle release or lengthening, tendon transfer, osteotomy or arthrodesis to treat the contracture. Okay, what are the functional prognosis that we want? Okay, the best indicator of how the child is going to do is how the child is doing. Okay, how do we prognose this child able to walk later? How do we prognosticate that? Okay, it depends on what the patient can do at during our assessment. Okay, if we see the child have independent sitting occur by age 2, okay, prognosis for ambulation is good. Okay, this is by Molnar, study by Molnar. So if the child able to sit independent by the age of 2, usually they can sit at the age around 6 to 8 months. Okay, the child able to sit independently around age 6 to 9 months. Okay, so but in CP they will have delayed sitting, delayed walking. But if the child CP child able to sit independently by the age of 2, you know, later on patient will have a good prognosis for ambulation, either with walking aids or assistive device, any other assistive device. Okay. If the child able to crawl on hand and knees by 1.5 to 2.5 years, is a good prognosis of ambulation by Badel. This is studied by Badel. Okay, so if the child able to crawl on hand and knees by 1+ to 2+ of age, and is a good prognosis for them to ambulate later. Okay. However, from both study, it noted that if the child has persistence of 3 or more primitive reflexes at the age of 18 to 24 months, it is a poor prognosis for ambulation. So you have to understand lah. Okay. So what is primitive reflexes? Anybody can answer that? Anybody want to answer? What is primitive reflexes?
Like motor reflex.
It's
Yelah,
normal
salah.
reflexes usually during the infant life that should resolve basically, or should go away.
Again? Can you repeat again?
There are normal reflexes present during infant life that should not persist after basically infancy.
Okay, basically it's right, but you need to add it is a protective mechanism for the child, for the baby. Okay, it's actually protective reflexes that appeared at a certain age, that appeared in exist in infancy, but however it will disappear at a varying age of the child. Okay, if there is persistent primitive reflexes, and you know that the child still, the nerve still did not mature enough. Okay, it's a protective mechanism. So go back and see what are the primitive reflexes. There are a lot, but at least you should know by now 10. Okay, at least 10. Okay, 10. You see my hand here. So you have to remember, because this will be asked during your short cases or long cases. Usually will be asked. Okay, at least they will ask you about mention 3 of all the primitive reflexes. So at least you know 10. That is good. Okay. What are issues when the CP child transit into adulthood or aging with CP? Okay, potential age-related changes and medical issue with CP are musculoskeletal changes such as osteoarthritis, okay, subluxation due to either overusage or excessive use of joints, okay, issue with chronic pain, okay, back pain, joint pain, yeah? And issues with reduced independence of mobilization. Okay, most of adult CP will use wheelchair for mobility. Okay, after a while, after some time, because of weight gain, because of increase in they have more function to do, they will use wheelchair for mobility. Okay. Goals for successful rehab of the child with CP include maximizing quality of life and functional independence, and not to forget to prevent any secondary complications, such as like just now I mentioned, is there any contracture, okay, complication of from the GI tract implication. Okay, despite CP being a static condition, it is associated with dynamic pattern of clinical manifestation that are lifelong and require interdisciplinary team to effectively manage them. Okay, this is the picture, many picture ataupun picture of CP. Okay, look back if you have Netter, you can Google lah, Google Netter. Okay. So I guess, do we have some time for video? Would like to show some video, can Will
Boleh,
this is,
Doktor.
boleh ya? Okay. Just an view of a good story, life story of a patient with CP.
Before we start the video, so I just want to tell I just want to announce that please after this lecture to all students, please stay in the same link because we're gonna have another common lecture after this with Dr. Ismail for medication, chemotherapy medications. So yeah, I think that's all. Thank you.
Dia dah start balik. Tak apalah, it's okay. Okay, so the aim is for inclusive environment and includes all the we say cerebral palsy child in our daily life. Okay, that is the aim for rehab, inclusive lah. Okay, I end up my lecture today. Thank you for all your attention. Is there any question? Do we have some time? Or it's already nearly 3 p.m. If you have any question, you can ask later.
We have time for some quick Q&A session.
All right. Okay.
I think so. If there's anyone who want to ask the questions or anything, just open up the microphone or write it in the chat box there.
Dekat chat box the question that is there.
Doctor.
You all dengar tak tadi video tu?
I know there is no sound actually, but nevertheless,
okay, maybe some problem. I thought that you all can listen to the music. Never mind. As long as you can understand what I want to present to you. Okay, if no question, then maybe I will.
I have one question, Doctor.
Okay, what question?
With regards to the GMFCS you mentioned earlier, is there a possibility after rehab for cerebral palsy to move from, for example, level 5 to level 2 or 3?
Okay, good question. Yeah. If you have identified a certain classification, classified the child in which level, usually there is some changes. Okay, maybe during before 2 years old, we see the patient. At that time, she's still in a developing age. Okay, still have some more thing to improve. So at that time, maybe they are in level 4 using wheelchair, but they have good in terms of tone, power tone, and control of the muscle. And therefore, when as they age, improve to 3 years old, 4 years old, 5 years old, they will have some more changes. Okay. When they are able to stand and walk during that time, we will change the level GMFCS from 3 to 2, 4 to 3 to 2 to 1. Okay. But if you already level the child with level 5, okay, usually, okay, patient with CP with level 5 rarely change to lower level. Okay, but other level there are still chance to improve to the subsequent level at the different age group. That's why they are age group less than 2 years, 2 to 6 to 12, like that. Okay, because they will have some more development that happen after you see them in the beginning. It's a good question. Any other more? Okay, I will give a copy of my slide to your leader. So I will email to your leader. Okay, so hopefully, who's the leader? Who's the one message? Message me.
Nafis, Doctor.
Nafis, okay. Okay, so I'll ask Nafis to give the email and then I'll email to you all the slide.
All right, thank you very much, Doctor.
If you have any question, you can always ask me in later. Okay?
Okay, Doctor.
All right. Thank you so much, Doctor.
Okay. Lastly, okay, hopefully I give some ideas, knowledge about rehab itself, rehab management for cerebral palsy. I am sorry with my limited knowledge, because we are human beings. Okay, Allah's knowledge is so wide, so many that we could not know everything. Okay, That's why we need to learn every other day, okay? Readings and read to improve our knowledge. So maaf atas kekurangan, okay? Yang baik semua dari Allah Subhanahu Taala. Yang kurang tu adalah kelemahan saya lah, okay? So hopefully to see you all again. Good luck in your future exam. And I pray that all of you will pass your exam, final year exam. Ni lah. Apa dia? I'm sorry, I cannot hear carefully. Clearly. Okay, I pray that all of you pass your final exam and become a good doctor. To our human being and to our ummah. Assalamualaikum warahmatullahi wabarakatuh.
Alright, thank you so much.
Thank you, Dr.
Assalamualaikum, boleh dengar?
Assalamualaikum, Doctor. Yes, we can hear you, Doctor.
Want to take 5 ke macam mana?
I think we can
just proceed, yeah?
Yes.
Okay, Assalamualaikum warahmatullahi wabarakatuh. Today's common lecture is on principle of chemotherapy. If there is any question, you can just raise your hand and then we can try to answer them immediately. So cancer is something that is rising because we are doing more investigation. We're going to detect more in our population. Taking example for the last 1 week or two in Susmet, I think we have diagnosed multiple myeloma, three new patients with multiple myeloma. Now, principle of chemotherapy, I'm Dr. Ismail Ibrahim. I'm the clinical hematologist, Department of Internal Medicine, and we have operated our hematology or chemotherapy daycare for the last 1 year roughly. In case you want to experience or see how we give chemotherapy, you can always come to our daycare. So outline of this presentation, we want to touch a bit on what is cancer and chemotherapy, and we're going to cover principle of cancer treatment and principle of chemotherapy, and we're going to give you few examples of chemotherapy. So what is cancer? Is basically a overgrowth of cells uncontrolled, and beyond above that it can also go beyond the original place. It can cause spread into the surrounding tissue. So it could be a disease that is in one side. It can go beyond the original place, called metastasis. Now the cause of cancer is to explain every single cancer, the cause of it will be a little bit difficult because it basically involve few factors to cause cancer. Whether that's because inability to die, like invading apoptosis, that patient will get cancer due to the cell keep growing without dying. You can see that very clearly in polycythemia rubra vera. If you put the cell into a cell culture, you just keep growing, without it stopping. Then it can also be a reason due to insensitivity to anti-growth signal. So it just can grow without a control. As we all know, there are few markers in our cells that limits the cell life expectancy, then it will just die off after a certain duration. Anyway, just to understand, by knowing the cause of cancer, then we can target that particular component or trigger that cause cancer in terms of our treatment. So it's very important before we decide on what chemotherapy to give to the patient or what treatment that we give to patient is to know the cancer very well. So it's a key point of giving chemotherapy is know the cancer. So making diagnosis, so making the right diagnosis by getting the right sample. And it's not enough by saying patient has lung cancer. We need to probably know a bit more whether this is a small cell, a non-small cell, because the susceptibility to chemotherapy will be very different. And even in cancer lymphoma, then the type of lymphoma is very important as well. We're not going to accept a simple diagnosis of B cell lymphoma, whether this is a diffuse large B cell, whether this is follicular lymphoma, is it high grade, low grade, all of that will determine what kind of treatment to give. The nature of the disease, so we need to understand whether this is a disease that is slow growing or this is a rapidly growing, or whether this is a curable disease. You know, whether this disease based on our knowledge is curable disease or this is not a curable disease. So that is important as well to pick the right chemotherapy. So what phase or when the cancer is newly diagnosed, definitely different than a cancer that is relapsing or refractory to the previous chemotherapy. Stage of the cancer is also important to decide what treatment to give. Some cancer require biomarkers like your prostate cancer, PSA, colorectal cancer, we have CEA, mainly probably not for diagnosis, but also for monitoring of disease. Another important part of knowing the cancer is the prognostic indices. So every single cancer have their own way of making a prognosis evaluation. So that is important as well because that will give a right expectation for each patient going through the chemotherapy. Another big thing about giving chemotherapy is to know the patient. So it's not only the disease status determine what chemotherapy to give, but the state of the patient is important as well to know, to decide whether the chemotherapy is suitable for them and what really the ultimate goal of the treatment that patient wanted to have. So that will require to assess patient's age, comorbidities that may interfere with the chemotherapy like renal failure, liver failure, and so on. Fitness, as you all know, ECOG status. So we need to know whether the patient is fit, fairly fit or not. And another important part of the patient factor is the effect of the disease onto the patient. So like lung cancer can cause breathlessness, liver cancer can cause ascites and so on. So that probably the main concern of that patient. So treating the patient should have a positive impact onto the effect of the disease. So if there is no improvement of that particular symptoms, then patient may not perceive the treatment will be any beneficial, any benefit to them. And how would you treat cancer? So cancer is not treated solely by chemotherapy. It can be treated by surgery and that may be enough. Some cancer is very radiotherapy sensitive, like your lymphoma is sensitive as well, like skin cancer is very much sensitive to radiotherapy. So that's a big treatment role in giving radiotherapy. Chemotherapy, we want to discuss now, and hormonal therapy is also a part of cancer therapy. For example, breast cancer that you give estrogen receptor antagonist. Immunotherapy, like CD20 in monoclonal antibody in lymphoma, or nowadays we have the PD-L1 inhibitor like nivolizumab or pembrolizumab. Monoclonal antibody is a type of immunotherapy, Antibody conjugate is basically an antibody that is attached with chemotherapy like brentuximab vedotin. Targeted therapy is a term that we use when we are able to identify certain genetic mutation, and the treatment is very much targeting to that particular genetic mutation. Tyrosine kinase inhibitor is one example that we use in BCR, in CML. Tretinoin is basically your vitamin A, and that is used in APML. Tumor vaccine, that's another thing. I'm not going to go detail for every single one, but just to make you understand, treating cancer is not solely giving chemotherapy. However, we want to focus on chemotherapy. So what is chemotherapy? We're going to first focus on cytotoxic chemotherapy. Refers to agent that we give that cause cell death, prevent cell growth via different methods, either in inhibiting microtubule function that interfere with the cell division, protein function of protein synthesis, or DNA synthesis. So this particular diagram that you can see is to divide the mode of action for every single chemotherapy, whether it's interfering with the cell division at G1 phase, S phase, or G2 phase. Yeah, you can look at these slides later to go deeper. This is another slide that very much the same as the previous slide to show chemotherapy works at different places of cell division. I just want to highlight this corner, which is the BCL2 inhibitor, which is venetoclax. It doesn't really affect your cell cycle, but rather it induces apoptosis. Yeah. So it induces apoptosis, so it causes cell death. Yeah. So this is another diagram to talk about this and how a chemotherapy interferes with DNA production and cell division. But we understand, as we understand earlier on, that it's not only chemotherapy that we give, we also do other things to treat cancer. We need to understand that we don't only use one modality. We can incorporate a few modalities to treat cancer, whether that's combining chemotherapy and radiotherapy, or including surgery, or it could it be radiotherapy alone or chemotherapy alone, or it could be a combination of all, in doing a surgery, giving monoclonal antibody like HER2, like trastuzumab, or you can give chemotherapy before doing surgery to reduce the size, and following that particular procedure, then patient may continue on taking hormonal therapy afterwards for 2 years, 5 years, depending on their receptor status. So it's a combination of modality, not only one modality in treating chemotherapy, in treating cancer. And the chemotherapy itself is not one single medication or one single agent that we use. Is a regimen, so we call it a regime or a regimen. So for example, in treatment, in treating patient with cancer, in lymphoma, we give R-CHOP. We don't give one single chemotherapy. We just combine a combination of 5 different chemotherapy in treating them. ABVD and Hodgkin. In multiple myeloma, we give RVD, Cybot. That's all. I mean, we are giving a lot of chemotherapy in one go. Yeah. So that's what regime means, a combination therapy. At the same time, there is doses adjustment. So some chemotherapy are also designed that we are also designed that we need to increase the dose to improve their efficacy. So that are the one that we use a lot here, which is dose adjusted EPOC or R-EPOC, or even BIACOP. There's another regime called escalated BIACOP, where you increase the dose of chemotherapy to the max dose. If patient cannot tolerate, then you start tapering down. Okay. So that's why we call it chemotherapy regimen. Yeah. And we are giving chemotherapy to patient, we need to be very clear in terms of our goal of treatment, whether this is a curative intention, or we are only treating the patient to prolong their progression-free survival, i.e. we know that the disease potentially going to come back, but we want to prolong that duration that patient have a very stable or low level disease. Another term that we tend to use is control. So to control the disease is very much probably the same as palliation. So we don't have intention to really get rid of the disease altogether. When we mention about cure, i.e. eradication, so that involves giving a chemotherapy first as induction. So induction means you give chemotherapy to achieve remission, and remission means disease not detectable. And to achieve cure, we cannot stop at induction. We need to follow after that, followed by consolidation, i.e. you give a chemotherapy on a patient that is proven to be free from cancer from scan or whatever test that you do, in order to increase the efficacy and to reduce the relapse rate. Yeah. Another term that we use is neoadjuvant or adjuvant. Either you give the chemotherapy before they're doing surgery to reduce their size, or you give the chemotherapy after having surgery just to cover the patient in case they are left over after the surgery of disease. Yeah? Now, how to determine chemotherapy? What treatment to give? So I think I mentioned early on, you need to know the disease properly. So there is a disease factor. We need to know the patient very well. So patient factor. You need to also know whether the patient had similar treatment before, then probably not wise to use the same chemotherapy because patient may develop resistance to previous treatment. And other important things in our country is the availability of treatment, whether that's because it's not available physically in our country, or another issue is funding. So if you don't have enough funding to give an expensive medication, that there is a factor to decide what chemotherapy to give. Another thing about determining the chemotherapy is to balance the risk and benefit of giving chemotherapy. So we all know the chemotherapy was intended to cure or treat patient, but there are a lot of potential side effects that may be detrimental to the patient, that may be an experience that you don't want the patient to go through, knowing that patient may not be cured or patient is dying. So I think the principle is not to do harm, non-maleficent, and to make sure that we weigh the benefit versus potential risk, and to make sure that the treatment is worth doing to the patient. Knowing there are potential risks of having chemotherapy in terms of its adverse reaction or side effects, then we need to understand the side effect as well. Yeah. So first thing is to anticipate what adverse reaction it could be. Yeah. The chemotherapy reaction could be something immediate. It could be cumulative, i.e. you don't get it straight away, but the more chemotherapy that you get more profound side effects from it. And it may not be immediate, and it can also be a long-term side effect. So after a few years, you get the side effects. And it could be system specific, i.e. lung alone, or cardiac alone, or could be a generalized reaction like what we call IRR, infusion related reaction, monoclonal antibody. So if you give the treatment, the body reacts like having a severe inflammation, or something very specific like bleomycin, the affecting the lung, that you can get pneumonitis. And these side effects are not solely depends on the chemotherapy. but other comorbidities of the patient may make the adverse reaction bit more prominent or higher in terms of risk. Then we need to know the comorbidities of the patient, and importantly, we need to make sure there is no other medication that may augment or make the adverse reaction be more prominent. I just want to go through few adverse reaction or adverse effect that people could get in terms of immediate reaction. So the common thing that we always discuss is about nausea and vomiting. But knowing that as a potential adverse event, then you need to know in terms of each chemotherapy or chemotherapy regime, their emetogenicity, I mean how likely they will cause nausea and vomiting. So we know cisplatin, for example, is very severe, yeah, in terms of its nausea and vomiting, and ABVD as well. So in that group of patients who receive cisplatin or ABVD, then we give more anti-emetics. We need to give more anti-nausea and vomiting medication. Another type of nausea and vomiting is anticipatory. So if people can get nausea and vomiting not because of the chemotherapy, another reason they get all these symptoms because they learned before that if you get this chemotherapy, you vomit. Then there will be time that people just vomit before you give the chemotherapy. So because of the learned behavior, they can get anticipatory nausea or vomiting, and there is treatment that we can give to that as well, especially in young male patient. Infusion related reaction, the one that I mentioned early on, is a type of hypersensitivity. It could be a severe anaphylactic reaction, or could be a features of it called anaphylactoid reaction, but more commonly this infusion related reaction, they will get like a cytokine release syndrome that you need to know how to deal with it by using corticosteroid, antihistamine, and the way that we deal with it normally is to reduce the rate of the infusion. Another immediate chemotherapy adverse effect is coronary spasm, especially when you use 5-FU. People can get coronary spasm, and that can present like a MI. Kejap saya. Kalau tak ada pula, tak ada kalau ikutkan saya kata hari ini juga, tapi kalau tak datang esok. Saya tak adalah kata tak boleh, tapi dia cakap tak ada orang dia sebab okey, faham. So, kalau tak datang malam ni, risiko adalah kata dia kena terima risiko tersebut, dan kalau dia become unwell, dia kena call ambulance. Kalau dia become unwell today, dia kena call ambulance. Another immediate reaction people can get is hemorrhagic cystitis, especially when you're using high dose cyclophosphamide. In that setting, we use Mesna as well, which is a medication that reduces the incidence of cystitis in cyclophosphamide. Another immediate adverse effect is tumor lysis syndrome. This is another topic to discuss, but it's a factor of the disease and as well a factor of the use of chemotherapy like venetoclax. Very prone to get tumor lysis syndrome. Now, getting adverse effect of chemotherapy is, as I mentioned earlier on, it could be cumulative effect. So that's why people can get cardiotoxicity and anthracycline. When we say cumulative, you know that there are certain dose, a maximum dose that patient could get, and we tend to give half or even less than that for their entire course of chemotherapy. So we need to calculate the maximum dose of every patient allowed to get. Another thing is long-term adverse effect, apa namanya, then they can get secondary malignancy. For example, the use of beer cup in Hodgkin lymphoma are very well known to cause hematological malignancy or any other kind of malignancy. The use of immunomodulators well can be associated with certain kind of cancer, including bladder cancer. Now, system-specific toxicity could be divided into different systems, either hematological or non-hematological. I'm not going to go very detailed about this. Later on, we're going to go through a few examples, then we can learn from that. As I mentioned earlier on about nausea and vomiting, you need to know what chemotherapy cause very highly to cause nausea and vomiting. That's to give more antiemetics in patient getting more high emetogenic chemotherapy. We mentioned about hypersensitivity reaction just now. So it can happen mainly the use of monoclonal antibody, and we need to, it could be as simple as urticaria, but it can be quite severe, having bronchospasm, angioedema, or even worse, you can get cardiorespiratory arrest. Yeah. So what we tend to do in this patient, we give them corticosteroid, antihistamine, and paracetamol before the infusion. Going to a specific group of adverse effect is myelosuppressive effect. That could include anemia, thrombocytopenia, neutropenia, or lymphopenia, and each of them will cause a different problem. Like anemia, that you need to give blood transfusion or platelet transfusion. In thrombocytopenia, in patient with neutropenia, then they are exposed to different kind of infection, especially between day 7 to day 10. Yeah. So at that particular period, patients are advised need to be cautious in terms of their interaction with others. And some patients who are at high risk, depends on their age or location of their home, distance from the hospital, then we need to give them some measures to prevent infection, either giving antibiotics preemptively, or we can give them filgrastim, which is a granulocyte stimulating colony factor and a hormone that we to encourage the bone marrow to produce white blood cell. So for neutropenia or low blood count, there are a lot of factors that determine the severity of the neutropenia, whether that's patient factor or the chemotherapy factors. And that also determine how deep or how bad is the neutropenia, also how long the neutropenia will be. Yeah. So in this patient, I mentioned we give them GCSF. So we give them GCSF in order to shorten or to quicken the recovery time, so that hopefully with that patient are less exposed to infection. That will not change the overall outcome of the patient, i.e. the survival, but mainly to reduce shorten the hospitalization day and also fasten recovery. Okay. Another hematological adverse effect should be will include thrombosis, and that will be either determined by treatment factor, cancer factor, or patient factor. And some patient who we deem them to be at high risk of thrombosis, they need to be on and VTE prophylaxis by means of anticoagulant. Nowadays, we tend to use rivaroxaban, which is an anti-10A inhibitor. Another hematological complication is bleeding. And bleeding can be explained by having thrombocytopenia. Another reason people can get bleeding is it can also due to platelet dysfunction, and that is an example of the use of ibrutinib that also cause platelet dysfunction. And this patient who receive ibrutinib, they cannot really receive anticoagulant. Yeah. So early on we mentioned that chemotherapy are given as a regimen. Another component of a regime, apart from a different kind of chemo in one cocktail, and there is possibility of escalating the dose or reducing the dose. Chemotherapy as a regime is also given in cycle. So we don't give it in one go everything and then that's it. We give it in cycle really because to allow the patient to go through the phase where they get cytopenia and then to allow them to recovery afterward before we go to another cycle of chemotherapy. Okay. So the last part of this presentation is to go through a few examples of cytotoxic chemotherapy. So first is alkylating agent, the oldest class of chemotherapy. We are talking about the classical cytotoxic chemotherapy. So example of alkylating agent is cyclophosphamide. You can read later about the detail on how it works onto the DNA replication. Cyclophosphamide, ifosfamide, melphalan, we use it a lot for different kind of cancer, especially in hematological cancer. We use it a lot in lymphoma as well as myeloma. Side effects of alkylating agent, apart from the usual nausea and vomiting, it can also cause hemorrhagic cystitis. It's important to mention that. And I mentioned early on, in patients who receive high dose of cyclophosphamide or ifosfamide, then they need to be on MESNA as well, which is a prophylactic protection against bladder, against hemorrhagic cystitis. Another example of chemotherapy that we give cytotoxic is platinum agent, that will include your cisplatin, carboplatin, oxaliplatin, and we use it mainly in hematologic cancer. We use it as a salvage chemotherapy. It's quite toxic. It can cause severe nausea and vomiting and myelosuppression. At a higher dose, it can cause ototoxicity or neurotoxicity. And the dose of platinum-based chemotherapy will be determined as well by your kidney function. Number 3 is anti-metabolites. So the one that we use a lot is your methotrexate, which interfere with synthesis of DNA and RNA. And apart from that, we use 5-fluorouracil in colorectal cancer. I also use 6-mercaptopurine in ALL, and so on. The list is extensive, and it can be used for different kind of cancer. The main side effect of antimetabolite is mucositis, myelosuppression, and hepatitis. Another class of chemotherapy is topoisomerase 1 or 2 inhibitors. Example is we use a lot is anthracycline, like doxorubicin, etoposide, irinotecan or tepotecan. We use it for lung cancer as well. Okay. The main side effect of anthracycline is cardiotoxicity. It can happen acutely or delayed. Okay, and whoever receive anthracycline, we're going to tell them they're going to lose their hair. Next is tubulin active agent. So it's either zinc alkaloids or taxane. We use a lot of zinc alkaloids in lymphoma, vincristine, and we use vinblastine for Hodgkin lymphoma. Taxane, we use it for breast cancer. So it basically prevent the ability of the cell to divide during the metaphase during cell cycle. The main side effect of tubulin active agent is, if you're talking about vincristine and vinblastine, is neurotoxicity. So it could be just a simple tingling sensation, or it could be numbness, or it can also cause constipation as a part of neuropathy. So zinc alkaloids are coming from very specific flowers. Taxane is coming from this particular plant. The reason I'm putting this on just because some people like to go for traditional medication, I'm saying to them normally is the chemotherapy that we use now is not something like it's totally produced from the lab without very organic material. They are all coming from natural ingredients as well. Other type of chemotherapy would include bleomycin, mitomycin, or actinomycin, which are produced by bacteria. Hydroxyurea, procarbazine, they are another type of chemotherapy. Again, I think we touched about hormonal therapy earlier on. It's not really a cytotoxic chemotherapy, but it's also useful in treating cancer. Briefly, I'm going to go through a few examples of non-cytotoxic chemotherapy, the other chemotherapies. Yeah. So first is immunotherapy. So immunotherapy could be a monoclonal antibody like CD20 in rituximab. So it could also be a apa namanya kita panggil Allahu Akbar, PDL1 inhibitor, where we encourage the cell to be killed by your natural killer cell in the body, like pembrolizumab. Or some cases we can also engineer a T cell in the lab so that the T cell that we produce are able to kill the malignant cell. What we call it CAR T cell. So rituximab is an example of monoclonal antibody. We use it a lot in lymphoma. Example that we use is rituximab. The new CD20 monoclonal antibody is obinutuzumab. Daratumumab, which is not CD30, is CD38. Sorry, that's wrong. Targeting multiple myeloma, alemtuzumab is a campath that also used previously for CLL. Monoclonal antibody can also be conjugated. It can be attached to a cytotoxic agent. Then we call them antibody drug conjugate. And one example that we use is brentuximab, which is a CD30 antibody plus chemotherapy attached to it. We use it for patients who have Hodgkin lymphoma. You can also use it for patients who have some kind of T cell lymphoma like AITL or PTCL. Blinatumomab is also an antibody, but it's a bispecific. Rather than it induce apoptosis or cell death by binding to the cell, so it basically tend to do dia jadi macam orang tengah. So what it tend to do is basically it bring closer the cancer cell into a cell that going to kill the cancer. Yeah, so it's very interesting antibody. So checkpoint inhibitor, we know that cancer cell, the way that they survive is by producing a receptor called PDL1 or PDL that prevent the cell from being killed by the normal cell that normally find any abnormal cells that and kill. That would be your natural killer cell or dendritic cell. And what this treatment does is actually it blocks that particular receptor, and that open up an opportunity for your own body to kill off the cell themselves. The two popular drugs that we tend to use is nivolumab, the first one that we use for melanoma, and pembrolizumab, which is now expanding very rapidly, that we can use onto different kind of cancer. I earlier mentioned about the use of CAR T cell, where you engineer a T cell, a white cell that contain a very specific antibody, a very specific receptor that can identify the cancer, and then that T cell can induce apoptosis to that particular to the targeted cell. Targeted therapy I mentioned early on, by knowing a specific gene, then we can target that, and the first drug that use that concept is your CML, and that is your TKI, tyrosine kinase inhibitor. I mentioned earlier on about the use of vitamin A. It's not really a chemotherapy, but rather it's a vitamin that change the behavior of the cell from a dangerous cell in APML into more safe cell. When you kill the cell, you are not going to cause severe complication like the IVC. Okay. Okay, BCL2 inhibitor is venetoclax. I don't have the picture here. Sorry, 1 second. Yes. Itu berita baru lah tu. Kita bagi dia size dengan ni lah. Bagi dia baru lepas tu bagi dia balik. So berarti 60 je. Bagi 15 BB for 21 days. Lepas tu jumpa lepas tu OD. Kau jumpa kat site klinik saya lagi 3 bulan. Boleh je start dulu, kemudian jumpa kat saya sebulan lah. Jumpa kat klinik saya sebulan lah. Okay, BCL2 inhibitor. So this is the drug that we have that cause kita tutup ni. This is a drug that we have called venetoclax. It costs about 6,000 per box, and this is like a drug that I keep for patient to use. Somebody donated this. Okay. So it's very potent drug that can also cause tumor lysis syndrome. So there are a lot of other drugs that I did not touch here, but it's a long list. But just to understand the different modality of treatment that we can use apart from the conventional cytotoxic drug. So I'm going to stop here. I just want to open up for any question or query. Any question? Okay, if there's no question, what we'll do, I'll share the slides to your class representative, then you can read up later and go a bit deeper and try to understand that. Okay, we end there. So that's it. Assalamualaikum warahmatullahi wabarakatuh.
Thank you so much, Dr.
Thank you, Dr. Smile.
Thank you, Dr.